Does that look okay, T?
Yeah, your screen looks perfect.
Okay. All right. Well, thanks for coming for the second talk for the group. And this is more this is going to be more, I think, applied to the specific issue of dysautonomia in Parkinson's disease and related diseases. So let's see if I can get to the next slide here. Okay. We're going to talk about what alpha-synuclein, a particular protein, has to do with Lewy body diseases. Nowadays, Parkinson's is considered a form of synucleinopathy, but what is that? We're going to get into some detail about orthostatic hypotension, a fall in blood pressure every time the person stands up. And there are different causes for orthostatic hypotension. We're going to be focusing on neurogenic orthostatic hypotension. This means a fall in blood pressure because of a problem with the autonomic nervous system. Specifically, we're going to be talking about the sympathetic noradrenergic system. I'll remind you what that means shortly. And I'll be talking about the relationship between this alpha-synuclein and the cardiac norepinephrine problem that characterizes patients with Lewy body forms of orthostatic hypotension. And after going through all this scientific stuff, we'll get into what I think is the most important part of this talk, which is treatment. Specifically, treatment for the orthostatic hypotension, which I think is a prime manifestation of autonomic failure in Parkinson's. So to get started, as you know, Parkinson's is a brain disease, and it's a movement disorder. It's the movement disorder defines the disease. Somebody looks Parkinsonian because of the way the person is moving around. And the cause of that movement problem is known. It's from a deficiency of a particular type of chemical called a catecholamine, dopamine, in a particular brain center called the putamen. I'll show you where the putamen is in just in a minute. And you can see that there's just a drastic loss of dopamine in the putamen in Parkinson's disease. This is a PET scan, positron emission tomographic scan, superimposed on the person's MRI. And it's a PET scan that uses fluorodopa as the imaging agent. And these things that look like kind of slugs here are the striatum, and the main damaged region in Parkinson's disease is the back part of the striatum called the putamen. I sometimes refer to this as a sad clown's eyes. The beady eyes themselves are the head of the caudate, and then the eyeliner is the putamen. And in Parkinson's disease, what's lost is the eyeliner, and you can see you can't see really the putamen here on this fluorodopa PET scan. This is a typical appearance of the striatum in Parkinson's disease. If you look at the MRI itself, you don't see anything wrong. This is all a neurochemical thing. It's not an anatomic thing. And in order to see the lesion, which I think is kind of obvious here, you need to do some sort of imaging, such as with fluorodopa. So that's where the problem is in the brain. much more recently, our group discovered that there's just as much loss of norepinephrine, which is like dopamine's son in the catecholamine family. A loss of norepinephrine in the heart, there's just as much loss of that as there is loss of dopamine in the putamen. In this particular study, there's just a drastic loss of norepinephrine in the heart. What this means is that Parkinson's isn't just a brain disease, and it isn't just a movement disorder, and it doesn't involve just dopamine deficiency. Instead, Parkinson's, based on these data, Parkinson's is a generalized disease. It involves a form of autonomic failure because norepinephrine, as we'll get into, is one of the key chemical messengers of the autonomic nervous system. And let's take a look. Here is a different type of PET scanning. This is PET scanning of the chest. And what it shows is the heart. This is a normal volunteer. And this is the heart. You can see the heart. This is the blood flow to the heart on this ammonia perfusion scan. The ammonia scan shows where the blood flow is, and there it is there. And you can see, and fluorodopamine, which is a radioactive form of dopamine, very actively is taken up into sympathetic nerves. And the heart is loaded with sympathetic nerves. And you see that normally the fluorodopamine derived radioactivity in the heart matches the perfusion. In pure autonomic failure, which is a rare Lewy body disease, where there's a generalized deficiency of norepinephrine, you see the blood flow is normal in this patient, but you can't see the heart at all. It's really remarkable. This blob over here is the liver. That doesn't count. Well, this is expected. Pure autonomic failure involves a generalized norepinephrine deficiency, and what we're seeing here is the deficiency of norepinephrine in the heart. In multiple system atrophy, used to be called Shy-Drager syndrome, which can look very much like Parkinson's. The blood flow to the heart is okay, and you see the heart on the fluorodopamine scan. The sympathetic nerves are there. The apparatus is there. It's not being regulated right because of a brain disease. And in this patient with Parkinson's and orthostatic hypotension, you can see the blood flow to the heart is okay, but you don't see the heart at all on the fluorodopamine scan. It's very similar to what you see in pure autonomic failure, and very different from what you see in MSA. So one of the take-home points is that it's difficult to separate out MSA from Parkinson's with orthostatic hypotension, but one way to do it is by fluorodopamine PET scanning. Now here's a more current example of fluorodopamine and ammonia scanning. Things have gotten more refined since 1997, a quarter century ago, when I published that article in the New England Journal of Medicine. Now you can obviously see a beautiful horseshoe in this patient. This is the normal perfusion of the heart. That's the top of the liver. And here's the top of the liver on the fluorodopamine scan, but you don't see the heart at all. Or maybe you could hallucinate a little bit where the heart is, but it's very remarkable deficiency of that fluorodopamine derived radioactivity that points to Parkinson's with orthostatic hypotension. This is more of a summary of what we found over the years. Wow, it's been a dozen years since I published this. And in Parkinson's disease with orthostatic hypotension, essentially everybody with Parkinson's and orthostatic hypotension has this loss of fluorodopamine derived radioactivity in the heart. Very different from controls, very different from MSA. In Parkinson's without orthostatic hypotension, then it's kind of 50-50. About half of the people have low fluorodopamine-derived reactivity, half are probably normal. So we talked about fluorodopa PET scanning. You can see in these people, these are 2 Parkinson's patients. You see the sad clown's eyes are really messed up. There's no putamen back here, very little putamen radioactivity there. These are blowups. And meanwhile, even though these patients have pretty similar deficiency of dopamine in the striatum, this patient has normal innervation of the heart. This patient has no innervation of the heart, or you can't see any fluorodopamine-derived radioactivity anyway. So this provides an illustration that the movement disorder and the dysautonomia are independent of each other. You can have pretty severe Parkinson's and a fluorodopa lesion that's severe and still have normal innervation of the heart, or you can have no innervation of the heart. They're independent problems. So we're going to be talking about norepinephrine a lot because it's deficiency of norepinephrine in the heart that's causing that abnormal fluorodopamine scan. And take-home lesson for today is that norepinephrine is a deficiency of norepinephrine because of a problem with the sympathetic postganglionic nerves. Remember, this is the ganglion, and you have this long, wispy, non-myelinated fiber going to the end organ here. The symptoms and signs of norepinephrine deficiency in the body are syndromic. They're syndromic. There's more than one thing that people complain of or notice, and that's why it's important to see how orthostatic hypotension is related to a whole syndrome of symptoms and signs. Symptoms are complaints that the patients have. Signs are things that the doctor observes. They're measurable somehow. So orthostatic hypotension is not a symptom. Orthostatic intolerance is a symptom, an inability to tolerate standing up because you feel like you're going to faint or feel weak or see things or something like that. But it's a syndrome. So if a person has orthostatic intolerance, then the person could also have exercise intolerance and can have heat intolerance and can have lightheadedness after eating a large meal. All of these are from failure of the sympathetic noradrenergic system. I'm not going to go into the others, but when the doctor sees orthostatic hypotension, then the person should also be thinking about, well, what happens to the person's heart rate during exercise? Because the increase in force and rate of the heartbeat it requires an intact sympathetic innervation of the heart. So the idea is that sympathetic noradrenergic failure presents as a syndrome. It's not just one thing. Some of you probably recognize some of these symptoms and signs. This goes beyond just orthostatic hypotension. What are the causes of sympathetic noradrenergic failure? Well, the most common is drugs. And so when we see people in clinic who have orthostatic hypotension that's due to sympathetic noradrenergic failure, then we think about drugs that the person could be on for some other reason that would produce a failure of the sympathetic noradrenergic system. But high up there is Parkinson's disease. Now, earlier on, I mentioned alpha-synuclein, protein alpha-synuclein, and I want to just explain what I mean. This is a Lewy body. A Lewy body is basically an accumulation of junk inside a catecholamine neuron, not only catecholamine neurons, but especially catecholamine neurons. And it has a characteristic appearance, sort of like a sunny side up egg, if you're colorblind anyway. And it was found in 1997 that these Lewy bodies, which are a pathologic hallmark of Parkinson's, as well as PAF, as I mentioned before, it's a Lewy body disease. These Lewy bodies contain an abundance of alpha-synuclein. Nobody knew what alpha-synuclein does. People still don't know exactly what it does. But this is very different from what happens in multiple system atrophy. In multiple system atrophy, there's deposition of alpha-synuclein in glial cells. These are helper cells in the brain. They're not neurons. They're not nerve cells. They're helper cells. And inside the helper cells, that's where you see what are called glial cytoplasmic inclusions. So pathologically, Lewy body diseases and MSA both are synucleinopathies, but the Lewy body diseases are separate from MSA. There is some overlap. By and large, the most common synucleinopathy is Parkinson's disease. And about 30 or 40% of people with Parkinson's have orthostatic hypotension. Another important Lewy body disease is dementia with Lewy bodies, which can overlap with Parkinson's disease. PAF is that rare Lewy body disease that I may talk about a little bit later. It's important scientifically because it can evolve into Parkinson's or dementia with Lewy bodies or both. MSA does not evolve into a Lewy body disease. Does alpha-synuclein cause the autonomic problems in Parkinson's? Well, nobody's exactly sure, but in people who have genetic Parkinson's, inherited Parkinson's from mutation of the gene that encodes alpha-synuclein, a mutation is like a typo in the genetic encyclopedia. In people who have this very rare typo, then you can see that they have a loss of sympathetic innervation in the heart, just like in sporadic Parkinson's disease. So it does appear that, at least in these patients, the synuclein problem, the genetic synuclein problem, actually causes the cardiac sympathetic problem as well. This was from an autopsy of a patient who had PAF, and then it evolved into dementia with Lewy bodies and Parkinson's before the patient died. And this is the sympathetic ganglion tissue that was obtained post-mortem. This is normal. The blue is well, normal except for the person's dead, but didn't have Parkinson's or a Lewy body disease. Anyway, the blue there is cell nuclei, and the red is tyrosine hydroxylase, which is a marker of catecholamine fibers. Green, as you see here, green is alpha-synuclein, and you can see that in this patient, there's hardly any catecholamine fibers left. Instead, there are fibers of alpha-synuclein. So in this patient, there's no question that that the patient had an alpha-synucleinopathy. This kind of immunofluorescence approach for looking for sympathetic nerves and alpha-synuclein can be applied in living people with by skin biopsies. I'm not going to have too much time to go into it today, but there are 3 sympathetic neuroadrenergically innervated structures in the skin. The little muscles that cause your hair to stand up if you go out from a jacuzzi into a cold locker room, the sweat glands and blood vessels. And you can see that there's tyrosine hydroxylase. This is the marker of catecholamine nerve fibers. You can see these structures have catecholamine nerve fibers. These are sympathetic noradrenergic fibers. So you can actually see sympathetic noradrenergic nerves under a microscope. And this is normal erector pili muscle, the little muscle that causes the hair to stand up. And here was the skin biopsy from that patient who subsequently died, and I showed you the autopsy results. You can see that in his skin biopsy, he had deposition of alpha-synuclein inside sympathetic nerves. Red is the fibers, green is the alpha-synuclein, and yellow is alpha-synuclein inside the sympathetic nerve fiber. This slide just shows there's a lot of stuff going on here, but if you look at the fluorodopamine-derived radioactivity, which is down here, and you look at different measures of the amount of alpha-synuclein deposit, which is here, the people who have Lewy body forms of orthostatic hypotension are all over here. That is to say, they have a loss of sympathetic nerves in the heart, and they have alpha-synuclein detected in these sympathetic noradrenergically innervated structures in the skin. So I think there's a strong link between what you see in the skin biopsy in terms of alpha-synuclein in sympathetic nerves and what you see in the fluorodopamine scan. The blue here, I believe, are people who have orthostatic hypotension that's from an autonomic problem, but it's not a Lewy body disease, and you see very clear separation there. Well, that's about as far as I want to go with the science. I think you'll need to know about this to understand some of the details about management of autonomic failure. When I say management of course, there's many forms that autonomic failure takes in Parkinson's disease. A main one is orthostatic hypotension. It's not the only one, but it's the only one I'm going to be dwelling on today. You may remember this from the last presentation. When it comes to management of orthostatic hypotension in Parkinson's disease, the main thing is education, and we'll get into that in some detail. The second line management is non-drug treatments, and the third is drugs. We'll be going into some details here, but first of all, you should realize that in people who have orthostatic hypotension, they may not know it. They may have no symptoms at all. And so the only way to really find out is by measuring the blood pressure. I'm especially interested in the blood pressure when the person is standing up. If the person has orthostatic hypotension and is sitting, which is what's typically the posture when the person's in the clinic, then you could miss orthostatic hypotension entirely. It's important to recognize that there are symptoms of orthostatic hypotension, and people vary in what those symptoms are. Some people can't think straight. Some people feel like they're going to faint. Some people just feel like their muscles are weak. Some people have coat hanger pain, which is a kind of an annoying Charlie horse of the back of the neck and shoulders that comes on when the person's standing and goes away when the person lies down. So you have to recognize these symptoms to realize that you could be in trouble because your blood pressure is too low, and if the blood is not being delivered to the anti-gravity muscles of the back of the neck and the shoulders, then it's not being delivered to the brain either, and that's potentially dangerous. People with orthostatic hypotension in the setting of Parkinson's usually are worst in the morning. If they're worst in the morning, then you think about when you take your hot shower. Take it at night, not in the morning, and you adjust your medication timing. Instead of taking your medication around the clock, you take it mainly early in the morning before you get up, because that's when you really need the medication. Later on, you may not. Of course, people who have orthostatic hypotension in the setting of Parkinson's have a high risk of falls, both because of the orthostatic hypotension and because of the movement disorder. This means if you're on an anticoagulant or a platelet inhibitor or something like that because you have a coronary problem or you have atrial fibrillation, then you're at especially high risk of harm from a fall. If you're going to the airport or someplace where you're going to be standing for a long time, you should have somebody with you. You could get lightheaded after climbing a flight of steps, and of course there's a great risk if you fall down those steps. People who have orthostatic hypotension often have postprandial hypotension, and that means that their blood pressure goes down if they pig out. So I recommend that people with Parkinson's and orthostatic hypotension take frequent, small, snack-like meals. The bathroom is a dangerous place for people with autonomic failure and Parkinson's. People should be peeing when they're sitting, not standing, and they should avoid constipation. It's not just an annoyance; it's a danger, because when you do Valsalva maneuvers, when you're straining against the resistance, the blood pressure is going to go down. You're not going to be in a hot tub because when you're in it, you'll feel great. But as soon as you get out, because the blood vessels have relaxed, the blood pressure is going to fall when you get out of the tub. I don't have the time to go into Florida restaurant syndrome, but you can read about it in my book, Principles of Autonomic Medicine, which is available for free download from my NIH webpage. And finally, people who have orthostatic hypotension can feel okay when they're exercising. The hypotension doesn't occur during exercise that much because of the muscle pumping, but as soon as they're done, that's when the hypotension happens. That means that if you're in an exercise program, you have to be careful of what your posture is when you're done exercising, and be ready to lie down. So education is a key principle, I think you can see, for actually living with autonomic failure in the setting of Parkinson's. Now, when it comes to non-drug treatments, one is elevating the head of the bed on blocks. I'm not going to have time to go into why this is valuable, but you can just think of it as mitigating or preventing the shock of getting up in the morning. Overnight, you've kind of lost blood volume, translated it into urine. That's why people usually have to pee as soon as they get up in the morning. In a patient with neurogenic orthostatic hypotension, that small loss of blood volume is enough to cause that shock in the morning, and elevating the head of the bed on blocks will ameliorate that shock. Everybody with orthostatic hypotension in the setting of Parkinson's should have a medical alert bracelet. Air travel is dangerous for people with orthostatic hypotension in the setting of Parkinson's. Not necessarily because of the drop in cabin pressure, but because you have to stand for TSA. The bathroom in a jet is going to be real small, and you're not going to be able to lie down, et cetera, if you get dizzy. I think that people who have orthostatic and hypotension with Parkinson's should think about having a medical escort fly with them. Other non-drug treatments include water drinking. I'm not talking about sipping water as the day goes on. I'm talking about gulping 16 ounces of water, not Gatorade, not chicken soup, but water. And I'll show you what happens in a patient with orthostatic hypotension when the person drinks 16 ounces of water. And this is on average here. You can see 10 or 15 minutes later, the blood pressure has gone up, and it could stay up for like an hour. So it's a very, people vary, and not everybody's going to have this, but it's worth knowing about this this osmopressor reflex, and think about drinking 16 ounces of water in advance of doing something that is going to drop your blood pressure. By and large, pacemakers are no value for treating orthostatic hypotension, unless you have very specific cardiological indications. If you have sleep apnea and you have a CPAP device, you should realize that that increase in pressure in the chest from the CPAP will decrease venous return to the heart. And in general, whatever happens to venous return to the heart is what happens to the blood pressure. So this could be good or bad. Some people have blood pressure that's too high at night, and if they have a CPAP device, they could actually drop their blood pressure by just having the CPAP on. I think a heating blanket would also decrease the blood pressure. Whether compression hose helps is kind of problematic. They're very difficult and bulky, and they're good for varicose veins, but the problem with neurogenic orthostatic hypotension isn't on the venous side of the circulation, it's on the arterial side. So I'm not sure that compression hose really helps. An abdominal binder can help, but this means coming up with a type of binder that really doesn't, it's not really marketed at this point. You want something that you could, let's like a big blood pressure cuff around your abdomen, and when you're ready to get up from lying down, you blow up the cuff, and then the venous return to the heart goes up, and you might be able to tolerate standing better. Well, I'm not talking about a corset or something that's a constant thing. This is something that would happen, that you would have to blow up in advance of getting up. I've looked in the market. I haven't really seen this sort of thing in a way that would be satisfactory for orthostatic hypotension. It may happen. All right, the last part of this talk is on drugs, and basically I divide up the drug treatment in terms of whether there's denervation, as you saw in those amazing PET scans, denervation, sympathetic denervation or not. The reason for this is if there is denervation, if there's a loss of sympathetic nerves, sorry, right here, then the receptors for norepinephrine are looking for norepinephrine. They don't see it. And so the receptors become super sensitive. And so drugs that, it's a phenomenon, it's called denervation supersensitivity. And so drugs that act on the receptors, like midodrine, can produce a big increase in blood pressure by constricting blood vessels. Another way to exploit denervation supersensitivity is with L-DOPS, dihydroxyphenylserine, which looks like this. It looks very much like L-DOPA, except where L-DOPA gets turned into dopamine, L-DOPS gets turned into norepinephrine. And so the way L-DOPS works is kind of similar to midodrine. These receptors are looking for norepinephrine. They don't see it. L-DOPS gets turned into norepinephrine, and that reaches these supersensitive receptors. So if you have denervation, sympathetic denervation, then a drug that acts on alpha receptors, either directly like midodrine or indirectly like L-DOPS, could be very, very effective in raising the blood pressure. Well, what if you have intact sympathetic innervation? This is highly unusual in people with Parkinson's and orthostatic hypotension. This is the typical situation in multiple system atrophy. There, different types of drugs would be of benefit, I think. Atomoxetine blocks the reuptake of norepinephrine. And so there's more norepinephrine that reaches its receptors, and that's going to cause constriction of blood vessels. And pyridostigmine acts on the acetylcholine receptors that are responsible for ganglionic transmission. And when that happens, there's more transmission of nerve impulses in the sympathetic nerve. The sympathetic nerve is there in MSA. And then that'll augment the amount of norepinephrine delivery to blood vessels, as well as increase delivery of all the neurotransmitters of the autonomic nervous system to different target organs. So in conclusion, Parkinson's isn't just a brain disease. It's not just a movement disorder from deficiency of putamen dopamine. It also involves a form of dysautonomia from deficiency of norepinephrine, especially in the heart. The alpha-synuclein in skin biopsies inside sympathetic nerves is related to the cardiac noradrenergic deficiency in the Lewy body forms of orthostatic hypotension. The treatment principles are first education, then non-drug treatment, and only then drug treatment. And finally, if you know the status of the sympathetic noradrenergic innervation, this helps rationalize particular drug treatments. In the case of Parkinson's with orthostatic hypotension, drugs that exploit denervation supersensitivity, I think, would be especially effective. Finally, I want to thank our tremendous autonomics team for their help with the patients who we study at the NIH, and thanks for your attention. So I'm open to your questions now.
Thank you